Hi guys, sorry I'm in the dark here. I'm just got home, so I'm just going to do this quick recap for you. All right, so with cardiovascular, again, the focus with not only just the heart, but that peripheral vascular. Remember, looking at nursing history for the heart, and again, really keep in mind with this one, guys, what are risk factors for your clients when they come in with heart disease or heart problems or that peripheral vascular problems. There's modifiable factors and non-modifiable, which I'm sure you guys talked about in 117. Those modifiable factors are those things that they can do to improve their health. So their diet, stop smoking, exercise more. Again, like that heart healthy diet, cut down on sodium, regular blood pressure monitoring, going to, faithfully to see the doctor yearly. So keeping that in mind. The non-modifiable, again, goes with ethnicity, genetics, hereditary, gender, okay? Uh, so just looking, again, for that nursing history for the heart, looking at their medications. And when they come in, if somebody's coming in and they're having difficulty breathing, we're going to put that together with the heart because somebody could be having a heart attack and they are going to be dyspneic, right? So that just kind of basic assessment. Again, keep in mind the flow of the blood. So we know right atrium is where that blood that's going to come from the venous and it's returning from the body to that right atrium down to the right ventricle up to the pulmonary. It's going to get that oxygenation coming to that left atrium down to the left ventricle and then back out to the heart. But again, you have the atria and the ventricles are both working together, right? So like when the right atria is contracting, the left atria is contracting. Ventricles. So keeping that in mind. What is that heart rate that we're looking for? Not so much heart rate, I apologize. The heart sound. So normal is that lub-dub, lub-dub. And it's that S1, S2. S1 is that lub, and that is with your tricuspid and mitral valves closing. And the S2, the dub, is the aortic and the pulmonic valves that are going to close. So when you're hearing any of the listening to heart sounds, again, do we hear just that S1, S2, lub-dub, lub-dub? Does it sound regular? Does it sound irregular? If I hear a swishing, that would be a heart murmur, and that is that one of those valves is not tightening or closing sufficiently, and that blood is backflowing, or the other word, regurgitating. So you hear that swishing. A dysrhythmia can be too quick of a heart rate, over 100, which is tachycardic, too slow of a heart rate, which is bradykardia, or bradycardia, under 60, or it's an irregular heart. So I'm hearing that what they call the S3 or S4 or a gallop. And so again, all we need you to know is those S1, S2, right? And if you hear something abnormal, then you would contact the provider. Again, look at your intercostal spaces for that PMI, be able to articulate where the PMI is, and know again what is the top of the heart and what is the bottom of the heart. That top is the base, the bottom is the apex, and that PMI is going to locate at that apex, right? So you need to know that terminology, base, top, bottom, the apex. So again, with this, just kind of the PMI, the sternal notch, angle of Louis, and then remember to the PMI is mid-clavicular, fifth intercostal space. Again, our order of assessment is we inspect, then we auscultate. Keep in mind that acronym APTM, A-P-E-T-M, so aortic, pulmonic, Erb's point, tricuspid, and mitral. Again, the aortic is going to be on the second intercostal, just right snug up to that sternal border on the right side of the sternum. As soon as you cross that sternum, still staying at that second intercostal, you will be at the pulmonic. If you go down to the third intercostal, and again, now we're all hugging that left side of the sternum, that's Erb's point. Fourth intercostal is the tricuspid, fifth is the mitral valve. Okay. Again, with the murmurs, guys, you don't need to know grade, pitch, or quality. It's just that if you hear that swishing, sound, and some murmurs are very mild and some are extremely loud. So that's why they kind of get that grating. So again, it's just, hey, I hear the swishing. Oh, that's a murmur, and it's that valve's not working right. Slide 11 with teaching and risk factors again. So we're going, what are some resources that we can give for risk factors if needed? Again, it goes back to there's a lot of great education for folks. So is it diet? Is it to have their cholesterol and their triglycerides, monitor their lipids? Avoiding secondhand smoke, smoking cessation if they're the one who is smoking. Doctors might ask them to do preventative with a low dose 81 milligram aspirin, right? Again, remembering with the blood pressure, we know that you can have a little variance of about 10 points off between arms. And we are going to record the higher of the reading. However, again, if I do take a reading in the left, reading in the right, I do want to record both. But keep it in mind is generally the treatment would be based on that higher reading. Also, again, that 5 to 10 point discrepancy is fine. If it's varying more than that, then you really need to let the provider know. The carotid arteries, which are again up in the neck, we are going to palpate one at a time. And you're also, again, the carotid is a great indicator of that heart beating. So if we were like going for a pulse, the carotid is a great one to go, yes, there's good, I can feel that heart going, that pulse. With the history for vascular, again, so thinking of those folks that has that compromise in their circulation, looking at those legs and hands and feet. So is my patient complaining and of leg cramps, numbness, those paresthesias, feeling that skin? Do I feel a discrepancy in the skin? Is the one skin nice and warm and the other one is very cool, that extremity, right? Is it discolored? Is there cyanosis? Do I see that red rubor color we talked about? Are they have a habit of crossing their legs a lot, wearing really restrictive clothing? Let's see. Looking for that underlying medical history as far as do they have heart disease, that hypertension? Looking at, do we see any varicose veins? Do we see in that phlebitis, which is kind of that superficial red inflammation of those veins that you can see? And then also, we said one of the biggest things is diabetics are at a very high risk for cardiovascular peripheral disease because how the blood sugar really affects those blood vessels. Okay, sorry, I had to go let my dogs in and out. Okay, so I'm looking again at slide, looks like 13. We talked about the with the legs and so forth, and if we're screening for our folks, are they in those paresthesias, pain, swelling, discoloration? Another thing too, though, was again, does walking or standing or sleeping aggravate or relieve it? Because again, depending on if it's arterial or venous, some patients can complain of standing or walking, and then when they stop, it can reside or feel better. Okay, let's see, slide 14 just talked again about with those carotid bruits. That's how you pronounce it, but again, the spelling is B-R-U-I-T. We talked about those, our blood vessels, when they're showroom perfect, are, a certain size. Blood's going through very well. When those vessels start to become diseased or damaged, they will start to narrow, they start to harden. And now think, that blood is not going to go through those vessels like it was when it was showroom perfect, right? So if whatever the causative factor is that's damaging those vessels, whether it's plaque buildup, whether it's a history of smoking, it's a history of hypertension, that is all going to put those vessels, those carotid arteries is what we're talking about specifically, at risk for becoming narrow, and that is going to decrease the amount of blood that's going to go to that brain. And so again, if you are assessing the carotids with the bell of your stethoscope, you could hear that swooshing sound. So again, it's called a Bruit If it's in the carotid, or if you're listening over that abdominal, over the aorta. If you're listening in the heart, it's called a murmur. And that is just, it's an abnormal sound. So for bruits, it's going to be because those vessels are becoming occluded or narrow or hardening, and that blood is really having a hard time getting through, or they're turbulent. And in the heart, it's because of those valves. So it's that you're hearing the blood, but those valves are not closing properly. Okay, 15 again is that JVD. Again, very important. How do I assess this? If you're really doing a good JVD assessment, that patient should be at a 45-degree angle. It's very specific in order to really reenact, or for the distension to be noticeable at the best, okay? 45 degrees. Again, it's due to fluid overload or too much fluid or fluid volume excess. Okay. Again, just the peripheral arteries up in the arm. So we have the brachial, we have the radial, and the radial's thumb side. Ulnar is towards the pinky digit. Pulses that are in the legs, we have the femoral, that's located deep in the inguinal. We have the popliteal, which is behind the knee. We have the posterior tibial, which is on the inner aspect of the ankle, or we call it the medial malleolus, so right on the inside behind, and dorsalis pedis is on the top. Okay, looking at slide 17, again, when we're looking for any kind of looking at these leg abnormalities. So I said you can see skin color changes. So you can definitely see these folks that have either arterial insufficiency or venous insufficiency. And with the venous, again, a lot of times you get that kind of dusky, ruddy kind of red color that looks kind of dull. You can see what they call ulcers. So it's venous stasis ulcers on the legs. They look kind of like a punched out hollow thing with yellow tissue. Arterial, the skin can have more of a brighter red or pink. The skin can look shiny. There's a lack of hair growth. They can have ulcers, but they tend to be more towards the toes. So those are definitely signs that there is some kind of insufficiency in that vascular, in that peripheral vascular, that's stemming from either the heart complications or there's vessel disease or something like that. Then you have the DVT. So classic symptoms of a DVT. Again, I can have a bilateral. Most time it's going to be one leg or the other, or unilateral. The classic signs are you have an increase in circumference of the leg. One leg, the affected leg, will be larger than the other, typically around the calf. It can look red. It can look or feel warm. Okay, and then so swollen or the larger. So the edema, the color, the warmth, and then also pain. If it's a DVT, so deep vein thrombosis, and again, you may hear it as VTE, venous thrombosis emboli or embolism. Emboli is a clot. So keep in mind those signs. And why is it so imperative to watch these folks? Because DVTs, that clot, right? We're all talking about a clot. It can break off from where that it was originated from. It can travel through the body, and that is how somebody can have a pulmonary embolism, which is a medical emergency. Patients can die extremely quickly from PEs. Okay, so make sure you look back over blood clots in the leg. Again, we are not being assessed on pulse ratings. We talked if you cannot palpate a pulse, and I'm on slide 22, then you can use the Doppler to hear it. How also, when we're looking at the peripheries, again, not only just checking those pulses, but looking at those capillary refills on those nail beds. Checking the color, so capillary refill under 3 seconds. Do the nail beds look pink, or do they look dusky? Do they look cyanotic? Okay, are the extremities, again, an unusual temperature, so cool. The peripheral veins, again, with peripheral edema, we have pitting edema, and again, you do not need to know the stages. It's just saying that Yes, I know pitting edema, when I depress on the skin, it will stay there. It can be mild, it can be trace, it can be all the way up to very severe. And again, it is because the body's retaining too much fluid. Okay. We have varicosities or varicose veins. A lot of times it can be worse on one side than the other, but a lot of times, or like I said, it might be one leg that's more involved, but a lot of times, especially women are more prone to this, and you will see it affect both legs. It can cause a lot of burning, tingling, prickling, pain, and like I said, it is the veins become very weak because sometimes from prolonged maybe jobs from sitting or the obesity, a lot of times with pregnancy because you got that extra pressure can cause it. Sometimes it could be genetic. So those veins, what happened is we got those valves in the veins that keep the blood going in a direction, right? And they become weak, and so you got like this blood backing up, and these veins become engorged. So then you have the phlebitis, which is more of a superficial kind of inflammation of the vein, and people can develop this. People who have an IV, and we're always looking at those IV sites to make sure we're not seeing that redness. Kind of thinking back again with the deep vein thrombosis, DVTs, what are risk factors for those? And again, it's that prolonged traveling, whether it was flying or by car, because walking is beneficial, right? We need to walk or people will have more risk for DVTs. Nothing really with the lymphatic system, just being aware again, we've had to toe with that lymph. Changes or cardiovascular considerations with aging. Again, most of your geriatric is going to have some kind of underlying health component, whether it's hypertension, a congestive heart failure, atherosclerosis, whether they've already have some peripheral arterial disease or poor circulation. It's just as we age, right, things start to not be as effective or weak and so forth. Okay, and I think that's it. So, and then, so it was just that last question about you're checking the blood pressure. On the patient, left arm was 120/80, right arm was 115/75. What does that mean? We're okay with that because that's only a 5-point discrepancy, and again, you get up to 10. All right, guys, have a fabulous week.